Okay, so hi everyone. Welcome to our first IMAA, the International Microwave Ablation Academy session on thyroid today. I'm Oliver from Kenyon Medical, and I will be the host today. I would like to welcome and thank everyone for attending today. During the session, audience can send questions to the Zoom chat box, and they will be discussed after the presentation. Meanwhile, the whole session will be recorded for future education purpose. Now, please allow me to introduce today's speaker. Dr. Shuhang Xu is an associate physician of Endocrine and the Diabetes Center at the affiliated Hospital of Integrated Traditional Chinese and Western Medicine with Nanjing University of Traditional Chinese Medicine. Dr. Xu, please.
Okay, Oliver, thank you so much. It's my pleasure to be invited to join a very wonderful seminar. Today, I'm going to talk about how to perform microwave ablation, the treatment for benign thyroid nodule and a low-risk papillary thyroid microcarcinoma. And first of all, I would like to share the some experience and some research results with everybody, and then we can discuss some cases, and I prepare 3 cases for everybody: 1 nodular goiter and 2 micro PTC, and I think it may help you to master all these important skills. Okay, let me share my slides first of all. Okay, I'm so sorry. This is a new laptop, so I have to adjust some. Okay. This is what I'm going to talk about. That microwave ablation of thyroid nodules and low risk micro PTC, and we're going to talk about technology, indications, and some results of our clinical practice. Okay, first of all, let's talk about the principle of microablation for thyroid nodule and thyroid cancer. Currently, I think most of attendees know that there are several types of some ablation worldwide. This ablation was firstly introduced by our Italian colleagues and followed by radiofrequency ablation in Korea. And then our Chinese colleagues used microablation to treat thyroid cancer or other cancers. And then high intensity focused ultrasound was introduced by Hong Kong doctors. So what is the principle of some ablation? The antenna or the needle was heated by radiofrequency or microwave, and the heat may damage the cells and the tissues, and then these nodules and cancers was totally destroyed. So the microwave ablation is mainly dependent on the water. Therefore, it is more how to say useful for the cystic nodule or highly vascularized nodules. which means the intranodular blood flow is abundant. In this case, microwave ablation can rapidly blocked the or destroyed the intranodular vessels. Therefore, microwave ablation is firstly is the first choice for liver cancer because it hits faster and larger. This is the differences between microablation and radiofrequency ablation. And this is the microwave machine commonly used in our clinical practice from KU. Okay, before we start microwave ablation, my assistant helped me to prepare for the operation. This patient was put in supine position with extended neck, and we disinfected the neck. And before we started, we should reassure the location of tumor with surrounding tissue, and we should select an appropriate injecting path. And we also should determine the power and ablation project. And after we started, we should disinfect the skin and start the microablation. There are two key techniques in the treatment with microablation or radiofrequency ablation. First is moving shooting. This technique is first introduced by Dr. Jung-Wan Beck from Korea in 2013 when he performed radiofrequency ablation. Because the microwave ablation or radiofrequency ablation can only induce a very small ablation area, which is called ablation unit. So we have to drag the antenna or needle into the space of nodule to completely ablate the nodules. So we call it is moving shooting. And this is the main difference between microwave ablation or radiofrequency and laser ablation. When you start to use laser ablation, you have to insect 2 to 3 fibers into the nodule. And each fiber is too thin to move because it is too thin. However, the radiofrequency ablation needle or microwave ablation antenna is too tough that you can move it freely and to completely destroy the nodular tissues. So it's quite effective in the treatment of benign thyroid nodules. If you look at the data to compare the effectiveness of radiofrequency ablation and laser ablation, you may find the laser ablation can only induce 50% of volume reduction rate. However, radiofrequency ablation can cause an 80% of volume reduction rate. That means radiofrequency ablation has a better efficacy. The second key technique is hydrodissection. This is a very important technique to protect or prevent the surrounding tissues from thermal injury, including trachea, esophagus, recurrent laryngeal nerve, the artery, or the veins. This is very important. So this is the how we perform the hydrodissection for benign thyroid nodule. There are some key points of hydrodissection. You have to use normal saline for microwave ablation, but if the normal saline contains a little K, it's okay. But I commonly recommend a normal saline and use 21 gauge needle and puncture into the space between cervical artery or vein and the outer margin of thyroid, and some other organs and thyroid capsules through the isthmus, including the trachea, esophagus, or recurrent laryngeal nerve. the normal saline was injected continuously to maintain adequate hydrodissection during the ablation. This is more important for the treatment of papillary thyroid microcarcinoma, because the objective of treatment is different for benign thyroid nodule and micro-PTC. For micro-PTC, we have completely ablated any tumor cells. That means as much as possible. So we have to extend our ablation area. However, for the benign thyroid nodule, the main purpose of the treatment is to ablate most of the nodule tissue to decrease the thyroid nodule size and to relieve the compression symptoms, or to relieve the cosmetic problem, to solve the cosmetic problem. Therefore, the hydrodissection is very important to completely destroy the tumor cells, and with extensive ablation. And after treatment, an ice bag was used to compress the neck for at least 2 hours, commonly 4 to 6 hours. Currently, microwave ablation is used to treat several types of thyroid disease, including non-functioning benign thyroid nodules, auto-functioning thyroid nodule, low-risk papillary thyroid microcarcinoma, advanced thyroid cancer, goiter, Graves' hyperthyroidism, and lymph node metastasis. If we have some time, maybe we can discuss about Graves' hyperthyroidism. Currently, there is an expert consensus was published by Chinese experts, and I was involved of this work. And we recommend this technique can be used in the treatment of recurrent or persistent Graves' hyperthyroidism. But there's so many technical points or some other management points should be discussed in details. So therefore, this issue is still in debated. And there are some guidelines published in Chinese domestic journals or by some international societies. And this is the first English guideline for some ablation by our Chinese colleagues. And this is the first international guidelines for some ablation of benign thyroid nodule by European Thyroid Association in 2020. And this is the first international guideline for some ablation of malignant thyroid lesions by European Thyroid Association. This is very important for us to start the ablation work. Then also some ablation technologies is recommended by some international consensus. Okay, secondly, I'm going to talk about the microwave ablation of benign thyroid nodules. And later we have some videos for you, and we can discuss the technicals later. In this part, I'm going to talk about indications, efficacy, and safety. First of all, let's have a look at the indications which is recommended by Chinese experts and in international societies. Firstly, the nodule should be diagnosed as benign thyroid nodule by ultrasound, cytology, or histology. So you have to use ultrasound or fine needle aspiration, even corneal biopsy to confirm the diagnosis. And secondly, the patient should have some complaint like compression symptoms or cosmetic problems or hyperthyroidism caused by an auto-functioning thyroid nodule. I think this is the key indications. This is what is recommended by European Thyroid Association. And in adult patients with benign thyroid nodule that cause press symptoms or cosmetic concerns and decline surgery, image-guided ablation should be considered as a cost and risk-effective alternative option to surgical treatment or observation alone. And the ETA recommended against the use of thermal ablation for asymptomatic lesions. However, there are still many arguments about the indications. For a benign cytology, we know that there's still some possibility for false negativity. That means this nodule was diagnosed as benign thyroid nodule by cytology. However, it has like 3% of percentage to be confirmed as malignant thyroid cancer by the surgery. So how to exclude the risk of malignancy? Should we perform a repeated cytology or corneal biopsy? And secondly, what about the nodule size? 2 centimeter, 3 centimeter, or 4 centimeter? It really does it really affect our decision? And thirdly, the hyperfunctioning thyroid nodule. If this auto-functioning nodule is too large, are we sure that the thermal ablation can completely destroy the nodular tissue and reverse the thyroid function? If the nodule is too large, I think the possibility decrease. So what about the symptoms? Does the patient really feel it is significantly influence their quality of life? And also the cosmetic concern. I think the age or the needs may influence the patient's decision. And secondly, and lastly, what about the surgery? If a surgeon talks to the patient, maybe the patient received the surgery. However, if an endocrinologist talks to the patient, and maybe patients can choose microwave ablation. There's so many debates for the indications. So our doctors should balance the effectiveness and cost and safeties for patient. We should avoid over-treatment with microwave ablation or radiofrequency ablation. So here I would like to share some data from our single center. Currently, we finished nearly 1,000 benign thyroid nodule cases, and at the early stage, we treat 37 patients with microwave ablation. And during the first year follow-up, the nodular size decreased significantly by 83%. So the nodules decreased to a very small nodule. The patient was satisfied by the treatment. And also some minor complications occur, but it doesn't affect patient's satisfaction, including pain, swelling, voice change, and major complications. In my center, there's no major complications. Only one patient with primary hyperparathyroidism. She was treated with microwave ablation. 6 months after ablation, she still feel hoarseness. And this is the only one case who was found to have hoarseness after 6 months follow-up. I think the safety is quite good, favorable. What about the thyroid function after ablation? During based on this table, you can find the TSH level and free T4 was not influenced by the treatment. However, TG level, thyroid globulin level decreased significantly. It is very interesting. It may be because of the tissue was destroyed by some ablation. So what about the cystic nodule? Should we prefer microwave ablation or radiofrequency ablation, or we just do the SNR ablation? SNR ablation is also effective to the cystic nodule. Therefore, we performed a very small study. It's also very interesting. 61 patients was enrolled in this retrospective study, and 31 patients was was received external ablation, and 30 patients was received microwave ablation. In our study, one patient was transferred from external ablation group to microwave ablation group. Okay, let's see the final results. It is interestingly that external ablation has the same effectiveness as microwave ablation in the treatment of cystic or predominantly cystic thyroid nodule. It's very interesting. However, when we divided these nodules into two groups, a smaller size or a larger size, and interestingly, we found in the small nodule, external ablation has a better efficacy in the treatment of these cystic or predominantly cystic nodule. In the larger group, their efficacy is almost the same. Okay, so we recommend external ablation for the small cystic or predominantly cystic nodule, because we can do it again and again. Commonly, patients need 1 to 3 times of treatment. Only several patients cannot be solved by external ablation, and then was transferred to microwave ablation. And commonly, these nodules are hematoma or bleeding of the adenoma. So what about microwave ablation and radiofrequency ablation? Are they different in the treatment of benign thyroid nodule? This is the first randomized parallel open lab trial so far. And it was conducted by 4 centers in China. We are involved in this study. Totally 148 patients was enrolled in this study. In my center, 36 patients was enrolled in this study. I'm going to introduce the data from my center, and 1 month or 2 months later, we are going to analyze the whole data to compare the efficacy and the safety of these 2 technicals. Today, let's take a look at the data from our center. And during the follow-up, you can see the volume reduction is not different between these 2 groups. Even the radiofrequency ablation has a little bit better efficacy in the treatment of benign thyroid nodule. And this is the volume reduction rate. Even at the 3 months of follow-up, the radiofrequency ablation has a higher volume reduction rate. But when we finish the follow-up at 6 months, there are no significant differences between these 2 groups. And based on this data, we found there's no significant difference in the effective rate, which was defined by 50% of volume reduction rate. These are typical images from 2 patients who treated with microwave ablation or radiofrequency ablation. So what about the secondary outcome of 2 groups, including the cosmetic score or complications? Here, interestingly, we found that radiofrequency ablation has a lower cosmetic score. That means it has a better efficacy in the treatment for the cosmetic concern. There is no differences between of complications between these 2 groups. And the thyroid function is almost the same. before treatment and after treatment, and between these two groups. So this study tells us even there are some differences in some ablation techniques for benign thyroid nodules. However, the effectiveness of safety of benign thyroid nodules in some ablation therapy is generally favorable, even in different technical group. The indications for treatment should be carefully evaluated and patient-centered. We should avoid over-treatment, and the operator experience, observation time, and nodule size may be factors influencing the ablation effect. And lastly, let's talk about the low-risk papillary thyroid microcarcinoma. I think everybody knows that active surveillance is firstly introduced by Japanese colleagues to manage low-risk papillary thyroid microcarcinoma, which is mainly conducted by the Kuma Hospital in Kobe. And these Japanese colleagues found that most of the low-risk micro-PTC has a low risk of progression and lymph node metastasis. Therefore, they recommend some of low-risk micro-PTC can be actively followed by ultrasound, and these are the indications for active surveillance. And when we compare the indications for active surveillance and some ablation for low-risk micro-PTC, we found there are no significant differences among these between these two indications for active surveillance or some ablation. But the differences of treatment for benign thyroid nodule and low risk micro-PTC is huge, because the objective is totally different. For benign thyroid nodules, some ablation is just used to reduce nodular volume and improve local symptoms and cosmetic concerns. However, the objective for low-risk micro-PTC is radical cure tumor foci as far as possible. Therefore, for low-risk micro-PTC, we cannot use moving shooting because we have to avoid needle track seeding of tumor cells. And hydrodissection should be maintained to avoid thermal injury. And the intensity of treatment should be strong enough to kill tumor cells completely. And the area for ablation should be extended to kill tumor cells as much as possible. Therefore, the volume of ablation area rapidly increased in the short term and shrink afterwards, and some of them even disappear. What about the follow-up strategy? For micro-PTC treated with some ablation, an active surveillance was also recommended, and patients should receive a regular examination with ultrasound. If some suspicious nodule or suspicious neck, cervical lymph nodes was found, the cytology or molecular testing or corneal biopsy should be performed. Neck CT scan can also be performed if necessary. So the objectives is totally different. Therefore, the technicals, the follow-up is also different. Generally, the efficacy of 3 thermal ablation methods for PTC is almost the same. A meta-analysis showed the disappearance rate of micro-PTC after thermal ablation is 57.6%. And the recurrence rate is quite low as 0.4%. So it's quite safe in a short period. And some doctors also compare the efficacy of three technical methods for micro-PTC, and the safety is also favorable. The major complication rate is also very, very low. And we treated 200 patients with micro-PTC, and we also found the ablation area increased significantly after ablation and decreased step by step. At 6 months, at the 6 months follow-up after some ablation, and the nodule or the ablation area size decreased significantly, and there's no significantly differences when it compared to the pre-stage or some ablation. And some of the patients was found to have an absence of micro-PTC, and the disappearance rate also increased day by day. At 20-year follow-up, nearly 80% of patients was found to have absence of micro-PTC. So this patient was totally satisfied by the treatment. And these are the typical images for 3 patients who treated with microwave ablation. So what about the complications of microwave ablation? Half of the patients complained of mild pain, and this pain can be released in 2 hours to 2 days. Some patients may have hypothyroidism, but don't worry, the TSH level increased in a short period, and then it returned to a normal range. This is very interesting. What about thyroid function? It is almost the same as benign thyroid nodule. Thyroid function didn't affected by the treatment, and the thyroid globulin level decreased significantly. Therefore, we make a conclusion that the management of micro-PTC should be based on the characteristics of tumor, the patient, and the medical team. So we have to build, or we have to have a multiple disciplinary team, and to have a discussion about the treatment choice. An informed consent is required, no matter active surveillance or some ablation. Some ablation is valuable for micro-PTC, but the results are affected by the research team, medical team, and the observation time. Therefore, we have to balance the treatment benefits and risk. We should not overtreat patients with micro-PTC, because this publication is mainly from some experienced team. Whether you can use it in the treatment of micro-PTC and to solve the patient's problem is still required. It's still unknown. You have to practice it, and also you should have discussed with the surgeons, radiologists to exclude the lymph node metastasis before microablation and after microablation. Multi-dimensionally fixed ablation may be more suitable for micro-PTC. Okay, this is what I'm very glad to share with all of you online. And later, let's move on to the videos for microwave ablation. Okay, I'm going to share directly. Okay, this is a very young girl. She is a teenager. and she was found to have a nodular goiter. Cytology was performed to confirm it is these nodules are benign and no signs of malignancy and suspicious lymph node. Before we start microwave ablation, we performed a local anesthesia, and this video show you how we performed the local anesthesia and how my assistant helped me to perform the treatment. After the local anesthesia, my assistant helped me to perform the hydrodissection. You can see that this needle was injected into the space between thyroid nodule, between thyroid gland and artery, and even into the space beneath the thyroid gland to separate thyroid gland from esophagus and recurrent laryngeal nerve. Afterwards, we insert the microwave antenna into the thyroid gland. And after we assure the needle's location and to keep the patients in a safety status, we started. Okay, we start the microwave ablation, and you can see the hyperechoic change was shown in real-time pattern by ultrasound. And then we change it to another place of this nodule and start the microwave ablation again. And this is a long video, and we have to speed it up. Because the hydrodissection is maintained by continuous injection of normal saline, so the patient was quite safe during the whole process. We commonly don't worry about the thermal injury to recurrent laryngeal nerve. Because this is a nodular goiter, the size of nodular goiter is quite large, and we have to ablate both lobes. So this is quite a tough job.
对，其实是个加速，我看看它能不能耐受吧啊。
For a nodular goiter, the aim of treatment is not just to ablate nodules. And I think the main purpose of the treatment is to reduce the size of nodula to relieve the compression symptoms. So we don't care about any nodules. We just ablate the nodular goiter to reduce the thyroid goiter size.
对，给它打进去。
这个叶老师挺高，更难。爸爸，你先说。我俩这个吧，有个叫。
慢稍微有点烫啊，打慢稍微一点。这边。
Okay, we aspirate the cystic fluids and to reduce the size of goiter. It may help us
给了他，给
to
先放脚
finish
再打点酒精。
the ablation earlier.
好，从这里来，咱们把这个
And we
非
also
常好啊，坚持住，
we also maintain the hydrodissection in
建
the
议坚持一下啊。
in the
6个
lower
月结束了，
写一下右边抽了3毫升的暗红色粘液。
Okay, can you see the video?
有点快了，最后一点点，别急。
Okay, the right lobe was mostly treated by microwave ablation, and after that we inject some ethanol to prevent the recurrence
抽了1
of the
毫升对吧？
microwave ablation because there's some part of our
打
cystic.
了0.6毫升，
抽了
测这么大结节不容易。
Okay, this is the left lobe. We have to use the left hand to do the local anesthesia.
然后那个讲指把那个 focus 把 depth 调一下，假成镜片小一点。对，好，看到它的深部。好，对。
And hydrodissection is also required.
好，对，很好，哎，苏珊再打，非常非常，哎呀，好好，非常非常，哎呀，好的，稍微等一下，稍微等一下，稍微等一下，稍微等一下，好，再往下打，来再打，出这人再打，好的，好，再打，非常打啊。
And you can see this the left lobe was successfully separate
好啊，
from trachea
非常好，非常好。
and arteries. After that, we start
是多发一些。
microwave ablation. Some doctors may prefer the isthmus pathway, but commonly I would like to use the lateral pathway because it provides a larger space for you to perform the ablation. The main concern is the injury to recurrent laryngeal nerve. So we have to
开始了啊，
we have to perform
好
a
比说你
very
再坚
good
持个10分
hydrodissection
钟不到啊，
to prevent
相信你
the
啊，
some
相信你，哎
the
把
injury.
它当成高考。
Sometimes you have to leave some space.
好，非常好啊，这些小朋友今天很好，确实很棒，这是夸你，确实很棒。这些笑容啊，确实还是大人都需要有难度的啊，更何况你呢？很啊，好，我们看看能不能再坚持一下，好不好？哎，因为麻药已经打了不少了啊。
During the whole
很厉害吗？
process,
能坚持吗？
I commonly
很厉
will
害吗？
talk to the patient
还行啊。
at
好，我
some
们坚持
point
一下啊，我
because
我
I
我
want
我
to
速度高
sure
一啊。
whether she
哎我的
feel
速度比较
pain,
快
she feel the pain, or she may complain of a voice change or even hoarseness, and to determine the whole process.
嗯，这确实厉害啊，不怕疼。我觉得赵华平多勇敢，我感觉。赵华平不行，那赵华平一直喊疼。嗯，对他后面也挺好的啊，虽然一声不吭的坚持下来了。好，苏珊，你慢慢打就行了，没问。啊，对对对。对，嗯。好的，嗯好，嗯，要喝，好，好的。
没有啊，他两个都正常的吧？
我跟病人说到病房找韩雪，他说韩雪夜里做梦梦到刘院长带大家英语学习，然后我就看了看刘，张一才我感觉唯一的好朋友，真的，张一才到哪玩不停的就给韩雪发消息。好，谢谢你快了啊，非常非常棒，非常真的非常棒，非常非常棒，确实，啊，很好，最下面一丢丢了啊，坚持就是胜利，坚持就是胜利。高啊！下次我觉得是不是等出诊火检出来接个出诊，咱门诊统一的。快结束，确实快结束了，非常好啊！谢谢小朋友，很好。这小朋友今天确实很不错，很棒很棒。我感觉在下 我感觉买个百胜的，怎么说百胜做微创消融最好。我们这个西门的200万已经算可以，但是反正说百胜的更好。刚才看到10多万。好，有些也很好了啊，再坚持一点，确实非常棒，已经烧到最下面了啊，最后一点点小尾巴了。对。那后来坏掉了是吧？那个其实确实不错，而且好拿。可以考虑啊。有点疼是吧？好了，最下面一点小尾巴，哎呀呵，可能是想烧到它了啊，反正把它有点把它小尾巴完全给它烧断，坚持一下。好的啊，感觉已经烧得很干净了啊，烧得比较干净了啊。好，哎呀，应该是比较干净的啊，这样子把血流打开看一眼，非常棒，很好，好的，感觉差不多的数字了啊，小的我给它烫一下，有些最后一下啊，最后一点点，咱们说了，哎，不骗你，最后一点。
After we nearly ablated the whole area of nodular goiter, we have to reassure whether the blood flow was mainly blocked by the some ablation. So we do the color Doppler to see whether there is some blood flow exists in the intranodular area. If it exists, we have to treat it. Okay, let's see another case with micro PTC. This is micro PTC, which was confirmed by cytology and molecular testing. And this nodule was found in the left lobe. And before we start the ablation, we do the local anesthesia and also to separate the artery from thyroid gland at the first step. You can see this nodule is very close to the trachea. However, there's still some safe, safe area between the nodule and the trachea. So it's quite important for us to perform a very good hydrodissection to separate the thyroid gland from trachea. You can see the hydrodissection is quite good, and the thyroid was successfully separated from or isolated from trachea, and it's quite safe for us to go further. My assistant will continuously inject normal saline into the hydrodissection space to maintain it. And also, before we started, we separate the thyroid gland from some muscles again. And we don't want to these tissues adhere after ablation. Some surgeons complain of the thermoablation because it increased the difficulty for thyroidectomy after thermoablation. And some of them even refuse to perform surgery for this patient. It depends on the surgeon's experience. Under the guidance of ultrasound, you can see the antenna was inserted into the nodule. We commonly start from the lower part of the nodule or the cancer. And you can see the hydrodissection is maintained adequately. It's quite good. And we assure the location and the safety of other tissues. We started, and then started. The hypoechoic change mainly covered the space around thyroid cancer. But commonly, we have to change the location of antenna a little bit because it cannot completely cover the tumors to avoid any remnant of the thyroid cancer. We have to perform a multiple dimensionally fixed ablation. That means you have to drag the needle a little bit and change the direction into another part of the cancer and start the ablation. It may help us completely destroy the tumor foci and extend our ablation area. And we performed multiple dimensionally fixed ablation. Then we drag the needle out and compress the neck with ice bag for 2 to 3 hours because this nodule is very small. It is not the large benign thyroid nodule. Okay, the last case is micro PTC in the right lobe. Firstly, we performed the local anesthesia and separate the artery from thyroid gland. It's almost the same, but if you notice that we use our right hand, you may feel there are some differences between the ablation to micro-PTC in the right lobe and the left lobe, because you have to use different hands to perform it. It requires practice. And the thyroid gland was also separated by hydrodissection from the esophagus and the recurrent laryngeal nerve. The most difficult step is to perform the hydrodissection for trachea and thyroid gland, because in this step you have to use the left hand. So commonly in this step, I commonly was very careful. Okay, this that you can see the thyroid gland was successfully separate. My assistant continuously inject the normal saline to extend the hydrodissection. Okay, after that, we insert the microwave ablation antenna into the thyroid gland. It seems this is the antenna was located in the up part of the of this tumor. So the multidimensionally fixed ablation should be performed. You have to change the direction into another part of the tumor to achieve complete ablation. Okay. The ablation areas was extended to cover any possibility of tumor cells. And this is important to prevent the recurrence. In my center, only 3.1 or 2% of patients was found to have a recurrent thyroid cancer after some ablation. Half of them was found to have a newly developed thyroid cancer, and another half of these patients were found to have a metastatic lymph node by ultrasound, and all of them received thyroidectomy, and no recurrence was found afterwards. So it seems surgery is also a very good salvage treatment after microwave ablation, but it requires an experienced surgeon. Some surgeons refused to treat this kind of patient. So you have to have a very good multiple disciplinary team. The surgeons should be aware of the difficulty of the surgery for this patient. Okay, that's all for my presentation and videos for some ablation. And I am open for any questions for discussion, and I'm also very glad to listen to your experience and suggestions. Thank you so much.
Thank you, Dr. Xu. Thank you for excellent presentation and sharing the case videos. And I think we have some questions from the chat box. The first one is, what is the length and time of ablation cycle for each nodule?
So you're talking about the ablation time for a benign thyroid nodule?
I think so. I just read it from the chat box. So.
Okay. Commonly, the ablation time depends on the size of thyroid nodule. If it is too large, we commonly you have to spend more time on ablation. But commonly for a 10 millimeter nodule, I think 6 to 7 minutes is commonly needed. But do not spend too much time on ablation for one session, because the antenna is not tolerant for heat for more than 30 minutes. So commonly we finish the ablation in 20 minutes. Several patients require 25, 27 minutes, but it's very rare.
Great, thank you for that. And another question is, can you please elaborate on the local anesthesia technique?
Okay. The local anesthesia is performed to prevent the patients from pain, and this is very important. And I think the key point is you have to spread the lidocaine around thyroid capsule because the many nerves pass through the thyroid capsule. If it is not anesthetized, the patient may feel pain, but do not use too much lidocaine. This week I treat one female, and she is so tolerant to lidocaine, so I used like 20 milliliter of lidocaine, and after the ablation, she's a little bit unconsciousness, you know, she's a little bit unconscious, and she feels a little bit dizzy, and she cannot move her fingers and feet, so it's quite it's a little bit dangerous. So I have to say, commonly you just do a local anesthesia to prevent the patients from pain and do not use it too much. So that tells us that you have to speed up. You cannot do it very slow. You have to speed it up and treat the patient quickly and to finish the ablation.
Thank you for that. And we have another question. Do you prefer direct access over trans-isthmic approach? Also, do you keep the needle still in the middle of the cancerous nodule without movement?
Okay, thank you so much. Yeah, this is a very interesting question. And I know that Professor Jung-Wan Baek from Korea, he preferred trans-isthmus way because it can prevent you, it can help you prevent the injury to dangerous triangle, which is located in the thyroid gland, trachea, and esophagus, because the laryngeal nerve pass through this dangerous triangle. So if you use the trans-isthmus way, that can help you to avoid the damage to a recurrent laryngeal nerve. But from my experience, I use lateral way, and I insect the antenna laterally, and the risk of a recurrent laryngeal nerve injury is quite low. So far, like 1% of patients was found to have hoarseness after microwave ablation, but most of them spontaneously relieved in 1 to 6 months. Only one patient was found to still have hoarseness at 1 year of follow-up, but she told me she recovered like 90%. So I think the key point is you have to maintain a very good hydrodissection to prevent the recurrent laryngeal injury from some ablation. Based on this good hydrodissection, you can treat you can ablate the thyroid nodule freely. I don't think there's big differences amongst these two ways.
Thank you. And we have one more question. What are the imaging criteria to assess the efficacy of ablation post-procedure?
Yeah, there are two criteria for our clinicians to perform our clinical study and to discuss with the patient how the efficacy is after the treatment. Firstly, we can use volume reduction rate, which was calculated by the current or the current nodule size, and which is divided by the pre-operative nodule size. And commonly after 1 year of treatment, the volume reduction rate for benign thyroid nodule is commonly 80 to 90%. So it's quite favorable for most of the patients. Another criteria is effective rate. which was defined by the volume reduction rate by 50%. If this patient achieved a reduction rate of 50%, then he can be defined as success. So you can use the effectiveness rate. Then you can compare the technicals, the experience from different center. Mostly, patients will be satisfied by a volume reduction rate by 50%. They may feel a significant shrinkage of the thyroid nodule, and cosmetic problem commonly was mainly solved.
Thank you, Dr. Xu. So I think there's no more question. Oh, there's one more. Any cases about malignant lump nodule ablation and any other technical considerations?
Yeah. I'm going to. I'm very glad to share some one case with you. Please wait a minute. I would like to share the slides with you. Okay, can you see this slide? And this is the contrast enhanced ultrasound of a case of cervical metastatic lymph node. This patient received thyroidectomy for thyroid cancer. During the follow-up, her thyroid serum thyroid globulin didn't decrease into an undetectable rate, and which can be classified as an indeterminate response from treatment. Therefore, she received ultrasound regularly, and our radiologist found there's a suspicious lymph node in the thyroid bed, and the contrast enhanced ultrasound showed this is the suspicious cervical metastatic lymph node. Then the final aspiration was performed, and molecular testing was also performed, and the final results confirmed this is a malignant thyroid, a malignant lymph node. And before we start the ablation, we performed the hydrodissection. From this slide, you can see that this lymph node was successfully separate or isolated from artery, trachea, or esophagus. After that, the antenna was injected into the lymph node and completely destroyed the lymph node. And after microwave ablation, the serum thyroglobulin was measured regularly, and the serum thyroglobulin became undetectable. That means this lymph node was completely destroyed, and the patients became an excellent response after thyroidectomy and microwave ablation.
Thank you. And we have another question. Could you introduce RFA of parathyroid?
Pardon, please.
Could you introduce the radiofrequency ablation of parathyroid?
Parathyroid?
Yeah, parathyroid.
A parathyroid.
Yeah.
A parathyroid. Okay. This is a very interesting question. parathyroid is located beneath of the thyroid gland. It is more close to the recurrent laryngeal nerve, so it's more dangerous for clinicians to perform some ablation. So the studies is much fewer for parathyroid. Currently, I think some ablation is more effective to treat primary hyperparathyroidism, not for secondary hyperparathyroidism. Even there are some consensus statement from our Chinese colleagues was published, and these guidelines or consensus to recommend some ablation to treat primary and secondary hyperparathyroidism. But indeed, the some ablation for secondary hyperthyroidism is not favorable, and the pTH level can be can significantly decreased, but the hyperparathyroidism cannot be completely cured by the some ablation. So it's the disadvantages of the treatment in secondary hyperparathyroidism. However, some ablation is quite favorable in the treatment of primary hyperparathyroidism, which is called PHPT. And if you look at the studies which concentrate on this treatment for PHPT, you can find the successful rate or the success rate is in the range from 50% to 90%. So commonly, I think 80% of patients can have a normal PTH and a normal calcium level. But some of the patients may still have a slightly elevated PTH level. Even their serum calcium level is normal. How to explain it? How to explain it? This is very interesting, because if you look at the data from surgery group, after parathyroidectomy, there's still some patients have a slightly elevated PTH level. It may be because of the a little bit PTH resistance, because the patient have a long term of high PTH level and hypercalcemia. So the PTH is a little bit resistant to its receptor. Therefore, after you remove the parathyroid gland, and the patient still have a little bit PTH resistant. So you can see the PTH level is still slightly elevated. Another problem is most of these patients may have a vitamin D deficiency. So the PTH level is still a little bit higher. In these patients, vitamin D level should be measured, and if needed, the patient may be supplemented with the vitamin D. The main problem of some ablation for parathyroid is the hoarseness or recurrent laryngeal nerve injury, because the risk is much higher than the thyroid nodule. So you have to perform a very good hydrodissection, and during the whole process, you also need to talk to patient to make sure whether there is a voice change. This is very important.
Thank you, Dr. Xu. And we have another question. So is microwave ablation proved better outcomes than radiofrequency ablation in toxic thyroid nodules in your experience?
So far, there is no study to compare microwave ablation and radiofrequency ablation in the treatment of hyperfunctional thyroid nodule. So I cannot say which one is better, but from the its principle and its efficacy in the treatment of benign thyroid nodule, I don't think there's I don't think that there's a big differences between these two technicals. The main problem is the main factor or the key factor is the nodular size. If the size of hyperfunctioning nodule size is if the size of hyperfunctioning nodule is too large, the some ablation cannot completely destroy the nodule tissues. So the patient may still have hyperparathyroidism. So this is the key point. So European Thyroid Association recommend if the maximum diameter of this kind of nodule is less than 2 centimeters, some ablation can be recommended and easily destroy the whole nodule with extended ablation. However, when the maximum diameter is larger than 4 centimeters, some ablation cannot be that effective in the treatment of hyperfunctioning thyroid nodule. The radioactive iodine treatment or surgery may be required.
Thank you, Dr. Xu. Thank you. And I think there's no more questions for now. And I think it's time we wrap this up for today's session. Thank you, Dr. Xu, for the excellent presentation and the case videos, and also discuss all the questions. And thank you all the other doctors for attending today, and thank you for your time. Thank you.
Thank you so much.
Thank you.
I would like to email with if you are interested in the treatment with microablation, and we'll talk about the technicals and even clinical studies. Thank you so much.
Yeah, thank you. Thank you, everyone.
Bye-bye, everyone.
Bye-bye.